So enough with the housekeeping. On to our topic at hand. We are so fortunate to have our AAST president, Dr. Eileen Bulger, as our speaker tonight. Dr. Bulger, although she's been on the West Coast her whole career, started her career on the East Coast when she received her undergraduate degree from Johns Hopkins and her medical degree from Cornell. It was after that Washington State snapped her up as a surgical resident and then a critical care fellow, and she's been at the University of Washington ever since. She now serves as a professor of surgery and the chief of trauma at Harborview Medical Center, which is the only level 1 trauma center for adult and pediatrics in Washington State. She served as the co-PI for trauma with the Research Outcomes Consortium and the PI of the Seattle Crash Injury and Research Engineering Center. There are so many things that Dr. Bulger has done that I could spend the whole hour talking about them. And for those of you who don't know her, really knowing her is a privilege. As I said, she's our AAST president right now, and there have been multiple roles she's held for the AAST over the last number of years, and many different initiatives that we still see in the AAST and help keep it move forward. She's also served multiple leadership roles in both the Washington State trauma system, including being the chair of their state EMS and trauma steering committees. She was the president of the Washington chapter of the American College of Surgeons. And recently, she did serve as the chair of the American College of Surgeons Committee on Trauma, and at their presided over their 100th anniversary celebration just last year. We're fortunate to have her talking to us today about lessons learned along the way. So, Dr. Bulger, without further ado, we turn it over to you.
Well, thank you, Nicole, for that really kind introduction. And it is truly an honor to serve as your AAST president this year. When I was talking to Nicole about what I should talk about for Grand Rounds, she said, well, you should tell a story about your career and what you've learned. And I think Dr. Spain did a similar thing a couple of years ago when he was president, and I certainly learned a lot from that. So I hope that you'll find this interesting. I will say that, see if I can advance the slides here, that this is a completely unscientific thematic analysis. I have done no checklists or quantitative or qualitative work here, but a lot of introspection. And what I'm going to try to focus on are these themes that sort of came out of thinking about this for a long time. I'm going to talk about mentorship, which I think we all know is critical to our careers, but I think when you take a step back and you look at your entire career, you can see a pattern of mentorship that can be really informative. I'm going to talk about taking inspiration from our patients for both research and advocacy, because that to me has been a fundamental sort of tenet of the work that I've tried to do. I'll talk about the value of multidisciplinary team-based research, and along with that, the importance, I think, of building coalitions to tackle some of the big problems that we face. I'll talk about the incredible value I have found in engagement in our professional societies and ways that maybe we can improve that for our young people. And then ultimately the value of both peer support and peer mentorship. So those are the themes that I'm going to try to cover in the next 45 minutes or so, hopefully leaving time for questions. And I'm going to do this in a way that's not comfortable for me and not comfortable for many of us by telling stories. If you haven't read this book, Talk Like TED, it's a great primer on public speaking, really draws on the lessons learned from some of the most successful TED Talks that are out there. But I think that we often overlook this in science, where we present a lot of data, the value of storytelling. And so I'm going to try to adhere to the principles of this book and speak to my own passions, tell you some personal stories. I was joking with Dr. Riley a little bit before this that unfortunately this is going to provide information for my introduction at the meeting, but that's okay. I'm going to try to be innovative. I'm not sure there's too many jaw-dropping moments here, but at least something new. And then hopefully this will be memorable. So we're going to start with the theme of a lifetime of mentorship. And when I thought about this, I really dug back into, how did I get to where I am and who really had a major influence on that? And so I want to introduce you to my very first mentor. This is my grandfather. My grandfather was an engineer by training. In fact, no one in my family was in the medical field. My father and grandfather were both engineers. He was an incredibly bright gentleman who was really known for being able to fix anything. If it was broken, you brought it to my grandfather and he could fix it. And he loved to embrace sort of the latest and greatest in technology as it evolved during his lifetime. But he was a man of very few words. He was very quiet, seemed a little bit reserved and hard to get to know as a little kid. And then on the right side of the screen is my doll, Betsy. And Betsy is one of the first memories I have as a child. I received her as a Christmas present when I was about 4 years old. And Betsy was my best friend. And all of you who have children know what it's like when your child latches onto a particular toy and takes it everywhere they go. So Betsy was my well-worn and well-loved doll. And about 2 years later, she was very well worn. And around that time, I was visiting with my grandfather, and tragedy struck because somehow Betsy's head became detached from her body, which, as you can imagine, for a 6-year-old was pretty traumatic. My grandfather scooped us up, took us off to his workshop, and I really remember watching with amazement as he tinkered around and figured out a way to fix her, get her head put back on, cleaned her up, and actually made her look better than she did before when he handed her back to me. And he did all this without really saying very much at all. This is probably the first surgery I ever witnessed. I didn't appreciate it at the time, but really it was an example to me of the value of being calm under pressure, taking a thoughtful approach, and realizing that if you can just sort of take the emotion out of it and take the time away, you can come up with a solution to almost any problem. And I got to know my grandfather very well over the next several years, and he continued to serve as that role model for me. So I consider him my first mentor. I'm going to fast forward now to a freshman in high school, and I had the opportunity to attend this all-girls Catholic school in East Providence, Rhode Island, called St. Mary's Academy. It was run by the Sisters of Mercy. And there were very few nuns that were teaching at that time, but I got the opportunity to know several of them. And Sister Catherine Menard became an incredible mentor for me. She was a history teacher, very similar to my grandfather, very quiet, very unassuming, but she really saw her mission in life to inspire women to professional careers. She instilled in us the spirit that you can do anything that you set your mind to, and you just need to work hard and be engaged. And I think the other thing that really struck me from her mentorship was she pushed us out of our comfort zone. And me in particular, I was pretty introverted, still am, I think. And so something like public speaking was something that was extremely scary for me. But she pushed me both in the class and then over time, over the 4 years of high school, into public speaking roles, into leadership roles. And I give her a lot of credit for that. And I wrote her a letter several years later thanking her for that training and experience. So again, a great mentor coming through high school. So I went on to college at Johns Hopkins. I knew I had decided already that I wanted to go into medicine. And so I went there for the pre-medical education. And while I was there, I had the good fortune to sort of serendipitously land in an EMT class in the local community college. There were some friends of mine that were all pre-med, and they learned about this class, and we thought, well, here, get some practical skills. We could learn to take a blood pressure and some basic things that will really help us as we think about a career in medicine. But I was completely hooked. I really fell in love with this experience of working in the pre-hospital environment. I went on to an internship with the Baltimore City Fire Department, and then on to paramedic training school, sort of all while doing my pre-medical studies. I landed after that in this relatively tight-knit community of Elk Ridge, Maryland, which is just outside of the city, outside of Baltimore County, but very close to the freeway, so a very busy fire department. And, I was completely embraced by this community. This is a tight-knit community with generations of firefighters that have come through this fire service, and really families that are totally intertwined with the fire service in Howard County. And here I was, an outsider, a Hopkins undergrad, but they really took me under their wing And by working with them, I had incredible experiences. I got to go to fire school, become a firefighter and rescue training and learn how to cut people out of cars. And it was just an incredible time in my life where I really learned so much to shape the future of my career. And I'll allude to that in my research as I went forward. But I owe a lot to this entire community for really taking in an outsider and making me feel part of the family. At the same time, I also was very interested in scientific research, but I had absolutely no research experience. And so I sought out a position in a laboratory and landed in the laboratory of Dr. Whittam Hudson at the Wilmer Eye Institute at Johns Hopkins. And Dr. Whittam Hudson, as a researcher and immunologist by training, working on ocular herpes infections, which I, again, knew nothing about. But she really took me under her wing. She taught me the scientific method. She taught me to write. And this paper, which is the first paper on my CV, was the 13th paper on her CV, I found out later. And to her credit, she let me be the first author and let me present it at a national meeting. So really was an incredible mentor to me, again, early in my career, opening up my eyes to the world of scientific inquiry. So I went on to medical school at Cornell in New York City. And there are two people that stand out in my mind there, and probably neither one of them will remember their encounters with me. And I think, as a medical student, we have very fleeting encounters with faculty, but they can be incredibly impactful. And I think that it's important for us to now, in our current positions, to remember how much those mean to the medical students that we work with. But Roger Yurt is a trauma surgeon who was assigned as my mentor when I was a medical student because I was interested in general surgery. And he was the one who really helped me craft my rank list. He told me I should go to Parkland. That's where he trained. But if I didn't want to go to Texas, I could go to Washington. And so the cards fell. But really gave me incredible advice, which I think otherwise I wouldn't have even thought of going all the way to Seattle. At the same time, Kevin Tracy was a chief resident on the neurosurgical service. And Kevin Tracy is an incredibly energetic, bright, outgoing gentleman who just makes everything fun and exciting. And so this was my first experience on a surgical service and really got me thinking about surgery as a career. And Kevin had also done a tremendous amount of research during his residency training and really talked a lot about that, even on clinical rounds, about the importance of sort of translational research. He went on to lead a major research institute and has had an incredibly productive career. But I think, his influence, again, on a medical student spending just 2 weeks on his service was enough to point me in the direction of surgery as a career. So I owe a great deal to these two gentlemen who probably will never know it. And of course, then I had the great fortune of landing at the University of Washington for my residency program. And have been blessed to spend my entire career here. I've had really outstanding mentorship across the board. There's lots of people I could talk about, but I really want to highlight these four individuals. Dr. Mayer and Dr. Jerkovich have been my primary trauma mentors for my entire career. I started working with Dr. Jerkovich on research as a second-year resident, and then went into Dr. Mayer's lab after my third year of residency. And since then, we've continued to work very closely together on projects through the last 30 years. Incredible mentorship, incredible sponsorship. Dr. Jerkovich is the one who really got me involved in the local state trauma system and pushed me to get engaged through the state chapter, and all of that really opened up doors for me to get involved nationally as well. And the other two people on this slide here is Dr. Lori Langdale, who was one of the few women on the faculty when I was a resident. She's the chief of surgery at the VA and a critical care physician and just an incredible educator and has been a lifelong friend and mentor. And then Dr. Michael Kopis, who's a neurologist by training. He actually founded the EMS system here, both the ground paramedic system as well as the flight service, and was the director of our emergency department for over 35 years. I got to work very closely with Dr. Kopis. He had very high standards, which means he could be challenging to work with, but I got along with him extremely well. And what I appreciated most about his approach to life was that he was very much focused on equity and ensuring that everybody who walked through the door, regardless of their station in life, got the highest quality of care. And he instilled that in all of his trainees. That continues to this day. So I want to talk a little bit more about this environment of Harborview Medical Center and the University of Washington. And, you know, as you think about it, when you write an NIH grant or whatever, you know, there's that section on environment and you write, oh, I have office space and I have computers and I have these things. But I think, you know, the more I reflect on it, the good fortune I had to land in this environment had a great deal to do with my success in my career. Not only the incredible mentorship that I've talked about, but just the environment that supports your ability to explore whatever areas of research you're interested in. So Harborview Medical Center is a pretty special place to me. It's a mission-driven safety net hospital. We're a county hospital, but run by the University of Washington. It's a very high volume, high acuity referral center. In the last year, we had over 7,000 trauma and bird admissions. It has continued to grow since I've been here. And as was mentioned, it is adult and pediatric level 1 center for the state of Washington. But we have a broad geographic catchment area. We get patients from as far away as Southeast Alaska, from Western Montana. And so we do a lot of outreach and a lot of education across this entire region. We're also the Disaster Medical Control Center for the region, which became very relevant during COVID. This center has really led the development of pre-hospital care, particularly pre-hospital research and injury prevention, and I'll talk more about that. I also want to spend a minute on the Washington State trauma system because it is also relatively unique and a big part of the environment as it's evolved here. So the Washington State trauma system was established through legislation back in the early 1990s. Dr. Mayer actually had a big part in writing that legislation. And you can see that we've really tried to be an inclusive system. So every colored dot on this map is a designated trauma center, but we designate trauma centers from level 1 all the way to level 5. Really trying to be inclusive of the remote areas of our state, which truly are rural and have primarily critical access hospitals, making sure that they're engaged in the trauma system so we can get patients out of those areas and then into higher level centers. So the star in the center here is Harborview, which sits in Seattle. And you can see the yellow crosses are level 2 centers, which are in the most populated areas of the state along the I-5 corridor here, and then out in Spokane. And then the green triangles are level 3 centers, which really anchor their communities, especially in the center part of the state. And then the blue is level 4 and the fuchsia is level 5. So we have about 80 designated trauma centers in the state, but by statute, we've also tried to limit the number of high-level centers based on the population need so that we can concentrate the volume and therefore the experience and ideally the quality of care in the higher level centers. So it is a relatively unique model and has been a fascinating place to work and think about how we promulgate these strategies nationally. As mentioned, Dr. Kopos founded the EMS agencies, but we've been really tightly integrated with them ever since. Our paramedics and flight nurses are highly skilled. We provide all of their medical direction. They're intricately tied into our quality improvement efforts, and they have representation in our trauma council, and we provide all of their training. So we're the regional paramedic training center for all of these agencies. And because of their legacy, particularly around cardiac arrest research, they see research as part of their job. And so as a young and up-and-coming trauma surgeon with an interest in pre-hospital research, this was an incredible environment for me because I could do research in the pre-hospital space without a lot of difficulty, and that can be really challenging in a lot of communities. We also have the Injury Prevention and Research Center, which is a CDC-funded center and again provides incredible expertise in a broad array of injury prevention approaches and a lot of advocacy at the state level. So this has been a way for me to learn how to be an advocate locally and translate some of these programs nationally. And then finally, as a young faculty member, I have to say that one of my most pivotal experiences in my career was the opportunity to deploy to the Haiti earthquake. And this is relatively timely given current events. The tragedy of the Haiti earthquake was almost overwhelming, but I felt like that we had the opportunity to contribute. I owe mentorship here to Dr. Susan Briggs, who you can kind of see in this photo in the red T-shirt. This was our team on the last day that we were there. But Dr. Briggs really has been a pioneer in disaster preparedness in the surgical community, and she built within the National Disaster Medical Service 3 medical surgical teams, one in Boston, one in Miami, and then the third that she started in Seattle back in 2006. And so I was a young attending at that time, and again, due to the sponsorship and mentorship of Dr. Mayer, got involved in that team from the very beginning. And this was our first deployment to the Haiti quake. It was the opportunity to learn the challenges of operating in austere environments and to really think about disaster preparedness for wide-scale events. And these experiences have stuck with me throughout my entire career as well. And Dr. Briggs continues to be a great mentor for me. So sort of wrapping up this first theme, I have to express obviously a gratitude for the lifetime of mentorship and sponsorship that I've had, and I hope that you have had or will have in your career. And I think we can't underestimate the value of that. I think that in addition to that, though, environment really matters. And so when you're looking for your first job or your fellowship program, really thinking about the environment there. Does it have the resources that you need to be successful in whatever area you want to pursue academically? I think is critically important. And I feel incredibly blessed to have landed here, and it's a big part of the reason I've never left. I think it's also important, especially early in your career, to engage both within the trauma center and quality improvement and other activities, but also within your local or regional trauma system. That has given me a broad perspective that has really helped me as I've moved into sort of national leadership roles. So the next theme I want to talk about is inspiration from our patients. And people ask me all the time, especially when they're just starting out. They know they want to do academics, but they really don't know where to focus their research or how to make an impact in their career, which is really what this is all about. We all want to make an impact. We want to improve care in some way or improve outcome for our patients or our population. So I think my answer to this is that you should take inspiration from your patients and you should learn from your mistakes. And so I'm going to share some stories with you, again, from my own personal experience, where either I've made a mistake and I've tried to learn from that, or a patient or a group of patients has really been an inspiration to me. So I'm going to start with another story. This is the tale, I call the tale of 2 motorcycle crashes. And this goes back again to the time that I was a paramedic working in Howard County, and I had only been in the position for a couple of weeks or so when this occurred. So we were at the local community hospital, which was a very well-resourced suburban hospital. We just dropped off a patient. We pulled out of the parking lot of the hospital, and literally within 2 blocks of the hospital, we witnessed a motorcycle crash. Patient was unconscious, unresponsive, clearly critically injured. And I made the decision, I was the lead medic, that we should scoop and run. We're 2 blocks from the hospital. There's nothing we're going to be able to do here that's going to make a big difference. Let's just get him on a backboard and spinal mobilization and get him into the hospital. As soon as we rolled into the doors of that hospital, it suddenly dawned on me that we had made a pretty big mistake, because the nurses were chastising us for bringing this patient there. It was clear that there was chaos. They weren't comfortable dealing with such a critically injured patient. And I just didn't realize that they weren't a trauma center. And they didn't have a comfort level that made this resuscitation anything but chaos. About 2 months later, we got dispatched for another motorcycle crash. And this time we called a helicopter to take the patient to the level 1 trauma center. In this case was shock trauma. And the medevac service in Maryland is based off of the Maryland State Patrol. And at the time, they would only had 1 medic on board. So if a patient was combative or unstable, they would take a medic from the field. So in this case, I had the opportunity to fly with this patient to shock trauma. And there I witnessed a completely different resuscitation, a team that knew what they were doing. They were organized. They had, everybody knew what their roles were. And it really sort of sunk the lesson to me that the system of care around the patient often matters more than the individual provider. And importantly, the decisions that are made, often by inexperienced people in the pre-hospital environment, which I was at the time, have a huge impact on the outcome of patients. And so this decision-making and the thinking about the pre-hospital triage of patients became a longstanding interest in my career. And we translated that into a lot of work. I had the opportunity to work with lots of different individuals, lots of different groups. It's just a small smattering of the publications that we have done on the topic of pre-hospital triage, really trying to understand different age groups, the impact on different populations and different scenarios across wide areas of the United States. We formed a Western collaborative to pool our data to really understand this across all the Western states. In addition to that, I think, it's great to publish a lot of papers, but you want to see that those papers actually translate into a change in practice. I've been really blessed again through sponsorship and mentorship from Dr. Jerkovich to get involved with the field triage guidelines as they have evolved. They were initially developed by the American College of Surgeons, really by expert consensus as part of the verification criteria back in the late 1970s. But over time, as they became more evidence-based, they were taken over by the CDC. And there were multiple expert panels in 2006, 2009, and 2011, all looking at incorporating evidence into revising these guidelines. And I had the opportunity to sit on those panels. And then in 2021, when it became evident that the CDC really wasn't going to be in a position to manage the next revision of this guideline, we moved this into the American College of Surgeons Committee on Trauma with the support of the National Highway Transportation Safety Administration, and just recently completed a complete revision, which is evidence-based and restructured based on feedback from the EMS community. So from my perspective, again, looking at this from a 30,000-foot view, it's a great opportunity to take what started out as a mistake, an error on my part as a paramedic, into a whole line of research inquiry and then into changes in clinical practice. And that's the kind of impact that I think we all like to have in our academic careers. Now I'm going to tell you another story that haunts me still. And this is a 7-year-old gentleman. This is not him, this is a picture off the internet, but you can see pretty similar type of person. So a 7-year-old guy who was fell from a ladder while cleaning out the gutters. This is a very common problem in Seattle, getting ready for the winter rains. He had no medical comorbidities, is not frail by any metric that we would use for frailty. He was complaining of some chest pain and shortness of breath. So he was picked up by EMS and he was taken to the local hospital, which was a very well-resourced urban hospital, but it was not a trauma center. He had 4 left-sided rib fractures and a small hemopneumothorax. So a chest tube was placed in the emergency department, and then he was admitted to the thoracic surgery service where I was the intern. So I admitted this patient. I started him on IV narcotics because he had a lot of pain, put him on a PCA. Within a couple of days, he started to become delirious, particularly at night. He was sundowning. And on post-injury day 3, it was not witnessed, but we suspect he aspirated, and he started developing increasing respiratory distress. You can see a right lower lobe infiltrate on the chest x-ray. Shortly thereafter, he had to be intubated, transferred to the ICU, and he died from sepsis on post-injury day 7. And this really haunted me at the time. I was an intern, and this is a guy who looked pretty robust and pretty healthy and was talking to me, and had just a few rib fractures, and in just a week, he dies in my hospital. So is this a preventable death? Is there something we could have done about this? That led to the paper that I did with Dr. Jerkovich, looking at rib fractures in the elderly, which of all the papers that I've published is the one that's referenced the most. It's a simple retrospective single center review, but it really highlighted the problem. It called out the significant morbidity and mortality that's associated with rib fractures in this population. a very common problem, and could we treat it better? This led us to do then a randomized controlled trial looking at different pain management strategies, and ultimately to develop a really comprehensive approach to rib fractures, which we have implemented as a QI project, published on, and are disseminating as widely as we can. So again, taking what is a tragic outcome in an individual patient and trying to make a difference over time. Another group of patients that I've been particularly passionate about have been patients with necrotizing soft tissue infection. By nature of our referral base and our geographic catchment area and our interest in this disease, we see about 150 cases of true NSTI a year here, which is a pretty high volume. Most centers, most surgeons will only see 1 or 2 of these in their career. And so it can be a really challenging diagnosis to make early. As you know, it's rapidly progressive, can carry a high morbidity and mortality. And very frequently, patients suffer from system problems where their diagnosis is delayed. They may have inappropriate antibiotics. They may not have adequate debridement. You can see the top center picture here is a patient I received in transfer who they were certainly worried about, and they made a lot of incisions, but no tissue was actually debrided. And there can be significant delays in transfers. So all of these frustrations as a young faculty member led us to put together a research team on this disease and to establish an NSTI registry as a module off our trauma registry so we could track data on their outcomes. And similarly, we've published a whole host of different projects looking at NSTI, looking at predictors of mortality, looking at long-term outcomes, ultimately extending these to multi-center studies, and then moving on to actual clinical trials for a novel immune modulator, which looked very promising in preclinical studies. And, you know, depending on how you interpret the phase 3 trial, has some good signal, but not enough for the FDA to approve the drug, unfortunately. But again, trying to leverage an interest and a passion for a particular problem into solutions is a great way to go. And I'm going to end with one more story, and I suspect many of you have stories like this, and I could probably tell lots of different stories about victims of firearm injury, but this little girl has stuck with me for many years. So I took care of her. It's been several years now, more than a decade ago. She's a 7-year-old girl who sustained a gunshot wound that went through her right arm into her right thoracoabdominal region and then into the abdomen. She was injured out here on this peninsula, which seems pretty close to Seattle, but it's actually across a body of water. So if you go by ground, you'd have to take a ferry. Fortunately, we have a robust helicopter service. And so immediately when this happened, the system kicked in. She was transported by EMS to this level 3 center here while the airlift was en route. And so they rendezvoused at this center. And the call I got about her was from the ER physician there who had just intubated her and started blood products. She was very hypotensive, clearly unstable, and our ETA was about 15 minutes. And I think of this case a lot because really from a trauma system perspective, everything really worked well for this child. It worked the way it was designed. The auto launch, the rendezvous of EMS, the triage was appropriate, the initial care was appropriate. She went directly to our operating room. She had an injury that the bullet went through her right elbow, which really shattered that elbow and caused an arterial injury there, and then went through the lung, went through the liver, went through the duodenum, and through the IVC. And so you can imagine the audible bleeding from the inferior infracaval IVC. So the good news is that this patient did well. It was not an easy course. Spent about a month in the hospital, had multiple surgeries, had to have her elbow reconstructed, had to have her IVC ligated at the initial operation, and the long-term consequences that come with that. But she did well. And so by all means, this is a success story from a trauma system perspective, except for one thing. We didn't prevent this injury from happening in the first place. And so if you go back and you try to figure out why a 7-year-old girl was shot, the story is that there was a little boy who was in her class, who had lots of trouble at home and felt like he needed to run away and to be safe, he wanted some protection. So he took a gun from his mother's boyfriend's home, which was easily accessible to him, and loaded. She didn't realize. He put it in his backpack. He went to school that day with a plan that after school he was going to run away. And when he put the backpack down on the desk, the gun fired and it shot this little girl. So you would think that there's a lot of opportunity for injury prevention here. The initial legal system, the county prosecutor brought charges against the boyfriend for leaving this gun accessible, and was successful in that court case. However, it was overturned by the state Supreme Court, who said that this man could not be held liable. And so no one actually ever had any legal consequences for this horrific event. So I think this speaks to our passion around firearm injury prevention and a tremendous amount of work that we've been doing in collaboration between the AAST and the COT and really the entire medical community to think about strategies to address this as a public health issue. And I'm sure you can also tell similar stories that have stimulated that passion. So lessons learned really are that I think meaningful research and advocacy starts with our clinical experience. And the stories that we tell are way more impactful than data. It's not the most comfortable way for us to present things, but it's the way we need to get used to doing. And then I think it's important to recognize that your research efforts and your educational efforts can change practice both locally and nationally. And that's really what we're in this for. And I want to speak briefly then about the power of multi-center, multidisciplinary research. And I've had the opportunity to work with two large research networks over the course of my career. The first was the Resuscitation Outcomes Consortium, which was an NIH-funded multi-center clinical trials network, which was focused specifically on pre-hospital resuscitation, both for cardiac arrest and for life-threatening injury. And this was very early in my career that this was coming together. And I was trying to figure out what to write my first grant about when my mentor said to me, just do something with hypertonic saline. And you don't ignore Ron Mayer when he gives you advice like that. So my first R01 was a local pre-hospital trial for hypertonic saline, looking primarily at the immunology of the patients and their risk for subsequent ARDS. But that set it up so that when this consortium came together and they were trying to decide what we should do as a national trauma study, hypertonic saline was at the top of the list. And we were able to run two large multi-center randomized controlled trials, one in hypovolemic shock and one in traumatic brain injury through this network. And it was an incredible learning experience for me. But if we're going to answer our big questions, we really need these multi-center efforts to do so. The other is the Crash Injury Research and Engineering Network, which is funded by NHTSA. And there was an opportunity to really understand the biomechanics of injury after car crashes and think about how that influences the safety design and the safety features that are put into vehicles. And that too has some direct correlation with changes in vehicle design. Along with that, I think that we need to recognize that we need coalitions. We need to bring the community together to manage our large problems. And it's no surprise to any of you, I'm sure, that have been talking about this in the trauma community for years, that trauma research just does not get the recognition that it deserves relative to the burden of disease. You would think that the things that kill the most children in this country, the most young people in this country, would be focus of national efforts for research, but you can see on this particular graph, things like motor vehicle collisions, gun violence, and elderly falls really are under-resourced from a federal funding research perspective. This has really led to the development of the Coalition for National Trauma Research, which I've been really blessed to help bring together. And this is a coalition that seeks to really unite our entire trauma community. And you can see all the members there and their logos around the mission of really three things. The first is to advocate for sustainable research funding that's commensurate with the burden of disease. The second, to coordinate research efforts that span our professional organizations, so we're not all reinventing the wheel. And the final thing was to really enhance national infrastructure to support multi-center investigation. The two networks that I showed you before, they have a time limit. They're sunsetted by the funding agencies. And so we need something that's really sustainable that can keep our community working together to advance this multi-center type of work. And that's where Center comes to play. The project that I've been leading through Center really came out of the NASEM report, which was, if you haven't read it, a pivotal report that came out in 2016. It really assessed the current state of our trauma care in the US and where our gaps are and how we can improve those to address preventable deaths. And one of the recommendations in this report specifically called for the need for a national trauma research action plan. And so we went forward with a grant to the DoD saying, let's Center work on this. And we had 3 aims. The first was to really do a gap analysis of military and civilian trauma research to identify the priorities across the continuum of care. The second was to really dive deeply into the optimal metrics to assess long-term outcome, because we know that's where the field needs to move. And the third was to really look at regulatory challenges that we face in conducting this type of research and how we could make that better. And so this particular project is still underway. It's in the sort of wrap-up dissemination phase now. And I hope will provide data to continue to support the advocacy efforts, as well as future researchers who can explore many of the gaps in knowledge that we've identified. In addition to that, this report also highlighted a lot of challenges we have in our trauma system. And you all know that trauma systems have developed at the state and county level. Some of them are very well established and work very well, and others are very patchy and not well resourced. And there's no federal support for or federal standards or national standards for trauma systems. We have trauma center standards through the American College of Surgeons, but trauma systems really haven't been approached in a similar manner. So a lot of these things are highlighted, these challenges are highlighted in this report. And again, this is a big problem. And so the solution is going to need to be a coalition to work on this as well. And then there was COVID. And I think that we all realized during the COVID pandemic that the weaknesses in our healthcare system were many parts of the country were overwhelmed as different waves went through different parts of the country at different times. But there was a lack of situational awareness in most places, so that you couldn't really level load the system. You couldn't do interfacility transfers to hospitals that had capacity, because you just couldn't see where the problems were. And so this lack of statewide bed tracking systems and lack of coordination across geographic regions was highlighted, in the lay press. Here, an article from the Wall Street Journal, but also now has been highlighted in the scientific literature. And I think this paper that was published in the Annals of Internal Medicine, which really looked at the period between March and August of 2020, when we had that huge surge, should be a wake-up call for us. They modeling that 1 out of 4 COVID deaths could be potentially preventable if we could have better managed that surge. And you could think of other large traumatic injury events, whether it be earthquakes, hurricanes, and so forth, where having a better system in place would make a big difference. During this time, I was chair of the American College of Surgeons Committee on Trauma, and so we worked hard to try to, in real time, put forth some solutions. We talked a lot about regional medical operations centers, which exist in some parts of the country and not in others. Some were pre-COVID, some were stood up during COVID. But really, in the areas where these were well established, they provided a mechanism for that situational awareness and for level loading of hospitals. We worked with the Greater New York chapter of the American College of Surgeons to debrief their experiences, particularly in New York City, and publish those. And in May of 2020, after that first initial surge, we sent letters to all of the major city mayors and public health officials saying, now is the time, this summer, set up some infrastructure for regional coordination so that when we go into a winter surge, we're better prepared. Not sure how much traction we got on that, but that's an ongoing effort through the American College of Surgeons. And it's really evolved into this vision that what we need is a national trauma and emergency preparedness system. You can see that the Regional Medical Operations Center is at the heart of that, with the idea that if we had that sort of resource functioning day to day, collecting data from our healthcare system and understanding what the capacity is and helping triage patients, whether they be trauma or non-trauma emergencies on a regular basis, that would be easier to scale up than an emergency setting. And so when it comes to building coalitions, this is the next big coalition that we need to build. We've already started this process. The AAST is engaged in this through the college, but it's going to take a significant advocacy push to get federal attention and support for building this infrastructure. So lessons learned around coalition building, I really think this is the only effective way for us to tackle our big problems. We have to come together as a community, and we are stronger together. This is again, a harken back to my EMS days, but a very common event in many communities at the county fair is the fire truck pull, and you can see that it takes lots of people to accomplish that goal. And one way to do that, I think, is through our professional societies, and engagement in our professional societies. Gives us the power to speak with one voice and to work together on these big issues. And it's also a great place to just build your own community. And again, as an introvert, where if you told me that I had to go to a networking event early in my career, I would say that sounds really painful. Because until you start to know people, it really does feel almost stressful, the concept of networking. But honestly, it's absolutely critical. And what I have learned is that the relationships that I have had the opportunity to build through my engagement in our professional societies, both locally and nationally, have been pivotal in my career. And so I encourage you to identify a local or regional society to get involved in, because there you're going to meet people that are referring you patients, and you can work on issues in your local trauma system. And then to pick one or two national or international societies that are either clinically or scientifically relevant to you, and really dive in there and get engaged. Many of you have seen this slide. I presented this when I gave the Orions lecture at AAST a few years ago. It's the figure I'm most proud of that's in the Journal of Trauma on the sort of natural life cycle of progression in our professional organizations. But I think what it highlights to me is the need to do better. So the way you read this figure is you imagine that you're the baby penguin, you're a resident, a fellow, you're in the lab, and you're going to your first meeting, and you're usually taken by a mentor who you stick by, and they'll introduce you to people, but you feel pretty out of place. The next time you go to that meeting, maybe you're looking for a job, so you talk to some more of the bigger penguins, but you're still not very comfortable in that environment. Over time, you get a job and you start to go to the meeting with other people from your institution, and you kind of hang in that little clique, but at least you have people to talk to. And it really isn't until you join a committee or you get actively involved in some part of the organization where you start to meet a lot of other penguins and start to have people outside of your own circle that you get to know. And it's probably, I think, in my estimation, almost 10 to 15 years before you're in the entire crowd of membership where you feel comfortable at a networking environment. So my goal has been to try to accelerate this timeline, to improve engagement in our societies, to get people more engaged early in their career, so that you build those relationships, you feel more comfortable, and you gain all the benefits from that networking. My two professional homes have been really the AAST and the Committee on Trauma, and really incredibly blessed to work with both of these groups. There's a lot of crossover in our community. It's not a huge community, and so you end up working with people from both groups in both places. And I couldn't possibly capture in one slide all of the friends that I have made in this process that have really been an incredible support for me throughout my career, but here's a few of them, including people from my own division here in Seattle, but really friends across the country who have, and across the world, who have been incredible support for me. They've supported me in hard times when I've had difficult times, and they've mentored me, and we still communicate, very regularly. And so building this type of community is what it's all about. And getting involved in the professional societies gives you the opportunity to make these relationships and build your own community. And I would encourage you to do so. The last group I want to talk about, just to put a plug in, because it's a special group to me, is the Women in Trauma Surgery group. This group came together during the pandemic, really to provide some support for each other when we were all pretty stressed in the healthcare system. And this is initially just a group of friends, again, from our previous associations in the trauma community. And we called it "Keep Your Wits About You," which was a reasonable catchphrase during the pandemic. But really what it's evolved to is an international group now with over 400 members. It's open to everyone, and it's free to join. We're hosting quarterly webinars with interactive discussions, really trying to take on some of the most challenging topics in our careers and in our professional community. And we've now come under the support of the American Association for the Surgery of Trauma. So we're incredibly thankful to the AAST staff and leadership for being willing to support this effort and help us host these events. And so I would encourage you, if you're not already a WITS member, please just email the AAST and they'll add you to the mailing list. We're going to have our first in-person gathering at the meeting in September. And it's just a few of the members of the WITS community. It's an incredibly growing community. I think there's more and more women going into trauma surgery every year. And so it's great to see that community build as well. So I tell all my residents and fellows that they have to have a limitations slide in every talk. That way you head off the discussion. So I'm going to critique my own talk here. And what would reviewer 2 say about this talk? I think they would say that this is an inadequate sample size. I have only told you my own story, my own perspective. And so it may not be generalizable, but I hope there's some pearls in there that you can take away as you do your own sort of self-reflection. I have shared absolutely no data with you, just stories, but I hope that I've convinced you that stories may be more impactful than data in the long run. I have not had this talk reviewed by a statistician, and I probably overstate the conclusions. So in summary, again, what I want to express is a gratitude for a lifetime of mentorship. And I think the exercise of just looking back over your career and your life and thinking about those people who really influenced you is incredibly valuable. Look to your patients for inspiration, whether that's for your quality improvement activities, whether it's for research, whether it's for advocacy. They are our greatest strength. Seek out opportunities for multidisciplinary research and collaboration, because again, I think you're going to build relationships that way and you're going to solve big problems. Work on coalition building. We need to be united, not divided. Get involved in your professional societies, whatever is most relevant for you, and build your own community there. And don't underestimate the value of peer support. So I'm going to stop there, and I just want to thank you again, Nicole, for the invitation to speak today. And I think I left a little bit of time for discussion, so I'm happy to take any questions that you have. And my door is always open for anybody that wants to reach out and continue the discussion. So thank you so much.
Well, thank you, Dr. Bulger, for that fantastic talk. And we knew it was going to be a good one. But you always surprise me with pearls that you share. We talked to our medical students here about, they all want to do research in different things. And I found it poignant that, your first paper had nothing to do with surgery. It was herpes virus in an eye. Mm-hmm. So, you learned your methodology and you had your mentors. I may have found someone wandering my hallways.
Hi, Dr. Kestry.
Dr. Bulger.
Nice to see you.
I do believe he has our first set of questions for you.
So that was great. First of all, Eileen, I've heard various versions of this over my career many times, but I congratulate you for putting it together. I'm sitting here in a room full of learners at various stages in their careers, and I think it's really important. And maybe I walked in a second late, maybe you said this, but your career around trauma is something that could be easily modeled around anything, right? I mean, it seems like the key ingredients, you have to have passion for what you're doing. You have to surround yourself with a nice environment and mentors, people who are going to push you forward, right? And then you have to have a coping mechanism for failure, right? Because I can't believe that every single thing you wrote ever got published, right? So what I wanted you to just maybe touch on a little bit, the difference between a career and a job. You're clearly defining a career, right? So the people in the room are not looking for a job at the end of their training, they're looking for a career. And you gave them a really good mountaintop perspective of here you are now, but where do you want to be 30, 40 years from now in this growing career, right? But also people are worried about life balance and challenges like that. I mean, obviously you didn't go to work every single day and do surgery every single day. You had a life. So maybe if you could just talk for a minute on how you kind of balance all that stuff, right? Because your academic career has clearly been stellar, probably one of the more stellar ones in our community. But you have other stuff to do at the same time. So how do you keep your eye on the prize? How do you deal with the occasional failure that comes up, whether it's a clinical problem or whether it's, a research dead end? And at the same time, how do you have a family, have a dog, quilt, all those kinds of things?
Yeah, I didn't get into that side of things, but I have two wonderful girls and a great husband who I've been married to for over 30 years and two dogs. So I've been incredibly blessed, really, I think, again, by having a husband that's supportive, that was willing to stay home and help raise the children, and an incredibly supportive home community that's allowed me to do a lot of the things that I've been able to do nationally. I'm not sure that I've struck the best balance. I'm sure that people could do it better. And I think for every individual, that's going to be a little bit different. But definitely when my kids were little, I tried to spend much more time at home. And when I went home, I tried very hard to leave work at work, like not do email at home, not do work at home, not do epic notes at home. And I think that really helped me sort of focus my energy when I was home with my girls. When, what's your coping mechanism? It's your community, it's your peer support. And that might be your peers, that might be your support, outside of medicine. But I have found that, this is a tough job. Like this is not an easy job being a trauma surgeon or any type of surgeon. So having a peer support group within your community that you can turn to, that you can talk about a difficult case, that you can talk about difficult outcomes, I think that having that level of understanding and people you can turn to for that provides a coping mechanism that is invaluable. And I think during the pandemic that became even more evident, and was a lot of the motivation behind putting WITS together, was to really have that as an online community. I don't know if I answered your question, but I did ramble a little bit.
So there are actually two questions in the Q&A. One is from Tenda Sultani. She's a fellow at the University of Michigan. So she would like to know, how can trainees get involved in the efforts to build a national trauma system, and what types of research would best support this effort?
Yeah, that's a great question. So I think on the advocacy side, trainees can get involved through the American College of Surgeons, through the Resident Associate Society. That's a great mechanism to get early engagement in the college and to start to build networks. They have an advocacy committee. You can get travel scholarships to attend the Leadership and Advocacy Summit, which is held every April, which is a great, not only great training, but also the opportunity to see sort of advocacy in action and walk around Capitol Hill and meet your legislative aides and that sort of thing. So I strongly encourage people that have an interest in that to do that, because I think we don't learn how to be advocates until we really work with people who know what how to do that well. So those are all ways you can get involved. I think from a research perspective, there's a lot of unanswered questions in trauma systems. The NTRAP panel on trauma systems just recently, that paper was just recently accepted for publication, so it should be out pretty soon in the Journal of Trauma and Acute Care Surgery. And that will really give you a whole list of what are the top priority research questions in trauma systems that have been identified by that group. So I think that's a great place to start, to look for opportunities to better understand what an ideal trauma system looks like. And I think that there's work that absolutely needs to be done in the rural community, because while modeling might say, oh, just put a level 2 trauma center here and that'll solve it, there's no hospital there that could ever be a level 2 trauma center. So how do you build a system of transportation or other resources that provide the same access to care for patients that live in that community to the higher level centers? I think there's a lot of work to be done there.
So the other question is from Catherine Campos. She was a past Harborview Department of Surgery student assistant in your research endeavors. What she says is, hi, Dr. Bulger. What is one of the stories, areas of research, and public health advocacy that you're most looking forward to engaging in this stage in your career?
Oh, that's a good question. I think that from an advocacy perspective, it's those 2 areas I talked about. One is firearm injury prevention, which, we still have a long way to go to really codify that as in the eyes of the public as a public health and medical problem rather than a political problem. And so lots of work around firearm injury prevention advocacy, and trying to bring the entire medical community together again in a large coalition that will work together on this issue. And I think the other area is the National Trauma and Emergency Preparedness System, as we talked about. Really, how can we harness some of the lessons learned from COVID that highlight the challenges we have in our healthcare system to really build out this infrastructure and support for this infrastructure for regional operation centers, which I think will strengthen our trauma systems as well as our emergency preparedness. So to me, those are the 2 big areas that I'm focused on at the national level. Really trying to advance in the advocacy space.
So there's one more comment in the Q&A. Dr. Sultani would like to thank you for the great answer and the wonderful talk. So
Thank you.
We're coming up on the 6 o'clock hour, at least Eastern Standard Time, not Washington State time. So for those of you that do still have questions, please feel free to reach out either AAST office or to myself or Dr. Bulger. We'll make sure that we pass those along. Any final words for our audience, Dr. Bulger?
No, just thanks so much for letting me spend some time with you today. And I hope we'll see you all at the September AAST meeting, which will be in Anaheim, California. It'll be a nice place to bring the family. You can go to Disney on the way if you want. And we hope to see you all there.